वो तेज बोलेगा फिर. Okay, so let's discuss the obstetrics and the gynecology part. See, whenever we discuss the gynecology parts, we discuss about the obstetrics. So in the obstetrics, we discuss about the pregnancy, related to the terms related to the pregnancy. So the pregnancy, we know that we having the, I told you already these things, but this is the obstetrics part. So let's do it once more time. The preterm baby, when we call this preterm baby, that is if less than 37 weeks, we call this as the preterm baby. Then we having the term pregnancy, or the term baby. So the term pregnancy, we call it as the, when the baby will be having the duration 37 week to 41 weeks. 37 week to 41 weeks plus 6 days. 41 weeks and 6 days. 41 weeks 6 days. Okay, then we having the, in the term pregnancy also we having the early term. So when we call it early term pregnancy, the early term pregnancy we called it as when the there is a 37 to 38 weeks plus 6 days. Then we will be having full term baby. When we call the baby is the full term, or we call it the full term delivery. We call it as the full term delivery when it will be 39 weeks to again 40 weeks plus 6 days. 40 weeks plus 6 days. Then we will be having the then post term baby or the late term baby. No, not post term, we call it the late term. Late term baby. The late term baby we call it when it will be 41 weeks plus 41 week 41 week to 41 week plus 6 days. So we call it the late terms. That you should remember by heart. There is a late term, there is a full term, there is a late term. After that there is a post term pregnancy. After that there is a post term pregnancy. Where the post term pregnancy, if we talk, see, post term pregnancy, when we call it, when the pregnancy or the delivery occurs after 42 weeks. So we call it as the post term pregnancy. We call it as the post term pregnancy. There is a one more terms that we call the use during the like delivery times. Sometimes the childs they died at the before the delivery happens. So we call it as the abortions. See, there is two terms that is the similar terms. One term is the abortion and other term is what? That is the stillbirth. Abortion and stillbirth. See, when we call it abortions, abortion means that is the early pregnancy loss. That is the early pregnancy loss. That is the early pregnancy loss. Stillbirth is the, we can call it as the late pregnancy loss. Abortion, for the abortion, remember, we remember a criteria, any pregnancy loss less than 20 weeks, any pregnancy loss less than 20 weeks, we call it as the abortion or early pregnancy loss. When we call it the stillbirth, if it is occurring more than 28 week to term delivery, then we call it the term delivery or till delivery, like whatever the delivery, we call it the stillbirth to till delivery. There is a one more period, we call it as the intrauterine death. There is a intrauterine death of fetus. The intrauterine death of the fetus, when we call it as the intrauterine death of the fetus or intrauterine fetal damage, we can also term it as the intrauterine fetal damage. So we call it as when it will be more than 20 weeks, more than equal to 20 weeks. Stillbirth 28 weeks to till delivery. And also we can call the stillbirth is also included into the, it is the part of the, stillbirth is the part of the intrauterine death of the fetus. Whatever the pregnancy loss occurring after the 20 weeks, we call it as the intrauterine death of the fetus. But if delivery happens like after like 29 weeks and the baby is death, we call it as the stillbirth. Okay, I hope this is clear. Abortion, that is any pregnancy loss less than 20 weeks, we call it the abortion or the early pregnancy loss. Intrauterine fetal death of the fetus or intrauterine fetal damage, we called it as the, if more than or equal to the 20 weeks of pregnancy, we called it the intrauterine death. Okay, I hope every one of you know already what is the duration of pregnancy. Sometimes they can ask you, or it should be known by everyone, what is the duration of pregnancy. See, when we talk about the duration of pregnancy, we know that in months. In months, when it will be? It will be 9 months. It will be 9 months plus 7 days. What will the 9 months plus minus 7 days can be there. But if they ask you like for the lunar month, so there is a 10 months for the lunar month. For the lunar months. But if they will ask you in the yearly, that is for the yearly or in the days, that is the 280 days. That is the 280 days. And if how many weeks it will be? It will be 40 weeks. 40 weeks. So this is what normal duration of the pregnancy, 9 months plus 7 days, 10 months, 280 days and 40 weeks. That is the normal gestation. We can also call it as the gestation periods. What is the gestation period? The period of the pregnancy, that we call is the gestation periods. Okay, so this was little bit. Now let's discuss the some one other important topic for this question. We discussed that there will be something like oogenesis or the spermatogenesis. I hope every one of you know already. There is a two process. One we having the oogenesis and another we will be having that is the spermatogenesis. Okay, so this I hope every one of you know already. Screen is lagging. Is screen lagging? स्क्रीन तो लैग नहीं करनी चाहिए यार. सही है, वो बीच में हो गया होगा, कोई नहीं. मे बी ड्यू टू सम. नाउ इट्स ओके. ठीक है ठीक है. ओके, देयर oogenesis और देयर इज spermatogenesis. देखो अभी oogenesis and the spermatogenesis, I hope every one of you know. I'm not going to teach you what oogenesis and the spermatogenesis for now, because I want to just that you should know about what is the oogenesis and the spermatogenesis. Oogenesis, they starts at during the gestation periods, like when the baby is in the womb of the mother. So oogenesis start at that time. Spermatogenesis, they starts at the puberty. Remember that thing. It's spermatogenesis. If we talk the spermatogenesis, they start at puberty. And oogenesis, it starts in womb itself, when the baby will during the gestation period. So at that time we will be having the oogenesis. Okay. The one other common question they will ask you, that at the puberty times. Okay, let's first discuss about the menstrual cycles. That is the important point. See, menstrual cycles, how many days average menstrual cycle? Menstrual cycle. So menstrual cycle, that average period of menstrual cycle, that is 28 days. That is 28 days. Okay, so for understanding the menstrual cycle, we should know about something related to the hypothalamic pituitary axis. So every time we will be having some hypothalamic pituitary axis. So for that we will be having like the hypothalamus. Hypothalamus, we know that it releases the gonadotropin releasing hormones, and that gonadotropin hormone releasing hormone will act on the anterior pituitary. That will act on the anterior pituitary, and that anterior pituitary will release the FSH and the LH. That FSH and LH will help in the promotion of the or the stimulation of the follicles, and there will be the, I will write it everything, just listen me now. So there will be the stimulation of the follicles, and the LH, they help in the ovulations. But if I say that only LH, if I give you the questions, as you already heard these things lots of the times, there is a hormones called LH, luteinizing hormones, and another hormone is what? That is the another hormone is the FSH. Is luteinizing hormone, okay, giving the question here, which hormone responsible for ovulations? I will repeat, don't write now, I will repeat, write this question later. Which hormone responsible for ovulations? So your option is LH, FSH or estrogens. What is your answer? What is your answer? LH, FSH and the estrogens. Tell me what's the answer. LH. Okay, this is LH. Now see, if I wrote it like LH, FSH, A options, B options, and the C is both, and D is estrogens. So what will be the answer? So here the answer is the both. Okay, so remember for ovulation, if they will ask you which hormones is responsible, so remember the LH and FSH, both hormones are responsible for the ovulations. So let's discuss the hypothalamic pituitary axis. We know we will be having the hypothalamic hormone. Let endocrinally, everyone know about we having the hypothalamus. This hypothalamus, what they do, they release the GnRH. They release the GnRH in pulsatile manner. GnRH in the pulsatile manner. And this GnRH, gonadotropin releasing hormones. If anyone don't know the full forms, gonadotropin releasing hormone in pulsatile manner, this GnRH will act on the anterior pituitary. This will act on the anterior pituitary. So when this will act on the anterior pituitary, there will be the anterior pituitary, which hormones will be formed by the stimulation of the GnRH. They will release the FSH and LH. What they will release? FSH and LH. What they will release? FSH and LH. Now what happen? This FSH, if I talk about only the FSH, they will act on granulosa cells. They will act on the granulosa cells. They will act on the granulosa cells. What are the granulosa cells? These are the cells that forms during the menstruation, or you can say during the ovulation periods. So these are the granulosa cells. So this, when this FSH will act on the granulosa cells, so what will happen in the there? There will be the formation of the estrogen. There will be the formation of estrogen, as well as there will be the formation of inhibin B. There will be the formation of inhibin B will be there. There will be the formation of inhibin B. So these hormones will be there. After that, if we talk about like what the estrogens will do, so that remember, these estrogens will be having the negative feedback on FSH. They will having the negative feedback on FSH. So what they will do, they will try to decrease the FSH. When the estrogen will be formed, they will try to decrease the follicle stimulating hormones. They will try to decrease the follicle stimulating hormones. After that, what happen? The estrogens, what it will do, it have the positive effect or the positive feedback mechanisms on luteinizing hormones. The luteinizing hormones, LH hormones. So what happen? There will be the increase in the LH hormones. Okay, so these are the two conditions for the estrogens. That is very, very important. The estrogen, they have the negative feedback mechanisms on the follicle stimulating hormones, and there is a positive feedback mechanisms on the LH hormone that will increase the LH hormones. Okay, so all these things will occur at the puberty, at the time of the puberty. So when the puberty hits, the hypothalamus, they will release the GnRH, anterior pituitary, they release the FSH, FSH and LH. This FSH will act on the granulosa cells, and that granulosa cells will release the estrogens and inhibin B. Inhibin B Inhibin B, what they will do? For the inhibin B, remember, they have the negative feedback systems. They will be having the negative feedback systems. They will be having the negative feedback system. Means negative feedback system on the, again, FSH. On FSH, follicle stimulating. So further they will decrease the follicle stimulating hormones. What is the function of the follicle stimulating hormones? See, follicle stimulating hormones. Follicle. So what they will do? Follicle को stimulate करना. So they will stimulate the follicles formations. What they will do? They stimulate the follicles. Stimulate the follicles formations. They stimulate the follicles formations. Now what happened? Remember that we studied that there is an increase in the LH. What the LH will do? The LH, it will, what they will do? They will LH, cause the LH surge. There is a LH surge. They will act on the thicker cells. They will act on which cell? Thicker cells. Thicker cells also, they are the cells present in the primary and the secondary follicles. So this LH will act on the thicker cells, and this LH will also act on the granulosa cells. This LH will also act on the granulosa cells. What is the LH surge? LH surge is the sudden increase in LH. There is a sudden increase in LH, luteinizing hormone. There is a sudden increase in the luteinizing hormones. And also remember, this LH surge, we know that it's one question can be asked from here: who initiated the LH surge? So remember, that is the estrogens. So this estrogen is the hormones that initiate the LH surge. LH surge you will study in the menstrual cycle just now. See, if there will be sudden increase in the LH, and after that there will be the ovulations will occur. Okay, then if this more LH will be there, the LH will act on the thicker cell as well, and what they will do? They produce the androgens. What they will do? They produce the androgens. They will produce the androgens. In granulosa cells, or in adipose tissue, in granulosa cells or in the adipose tissue, this androgen in granulosa cells, when we talk about the granulosa, and there one more also granulosa cells also, and in the adipose tissues also, this androgen will convert into the estrogen. This androgen will convert into the estrogens by which enzymes? Aromatase. By which enzymes? Aromatase enzymes. This is again very very important point. So always remember, if there is androgens, so by aromatase enzymes they will be converted into the which hormones? Estrogen hormones. Where it will occur? In the granulosa cells as well as in the adipose tissue. Okay, so there is increased LH, they will act on the granulosa cells, thicker cells, and the LH surge. In the granulosa cells, what they will do? The androgens will be converted into the estrogens by the aromatase enzymes. Okay, in adipose tissue, when we studied about the adipose tissue, so there is one other enzyme that is we call is the the one form of androgens. We call that form is the androstenediones, and these androstenediones will convert into the estrogens, and we having the full some form of the estrogens like E1, E2, E3, E4 also, that we will study. But for now, just remember we have studied these things. Now remember that if when the LH surge will occur, or can I write it here? I think we have some space here. So when the LH surge will occur, it will occur 36 hours before the ovulations. The best time is the 36 hours before ovulations. But what if the questions, they will give you the options 36 hour, 32 to 36 hour, 24 to 36 hours. So what example you will prefer? So always prefer 36. They always prefer 36 hours before the ovulations. Then if this is not in the options, then prefer 32 to 36 hours. If again this is not in the options, then prefer the 24 to 36 hours. 24 to 36 hours. That you need to prefer. 36 hours if in the questions, mark that 36 hour. That is the best times for the before ovulations. Okay, there is one more things. That is LH peak. See, there is two term. LH surge means that there is a like when the estrogens will come, there will be the sudden increase in the LH hormones, and there is a LH peak. What is that LH peak? LH peak is the minimum amount of LH required for ovulations. Minimum amount of LH required for ovulations is attained. That is LH peak. And LH peak, it occurs 10 to 12 hours before the ovulations. 10 to 12 hours before ovulation. Okay, so this is the two terms that we discussed. So one term is the LH surge and another one we having the LH peak. Okay, this is the important point because they are making some base, and all these questions or all these one liners will be repeated in some topics. So that's why we need to familiar with all these things before our lecture has been started. See, if we talk about there is a actions of LH, the next one, what are the actions of LH hormones? So LH and the functions of LH hormones, they help in, I told you that they help in the ovulations. They help in the ovulations. They help in the ovulations. They also, remember that they are converting what androgens to the estrogens, and this estrogen is which form? That is the E1. This estrogens will be the E1 forms, and this is by the aromatase. And also remember one more point from here, this maximally present in adipose tissue, maximally present in the adipose tissue. If they ask you where the arrow, that's why in adipose tissue we studied that the androgens is converting into the estrogens. Okay, and female having the more adipose tissue, so female having the more estrogens. Okay, and here I told you, so there is a one thing that it help in the like formations of the the formation of ester E1, and they also help in the formation of the progesterone. How the progesterone will be formed? By the granulosa cells. The granulosa cells, what they will form? They will secrete the progesterones. That will be the less in the amount, but yes, that will be there. And this progesterone will further increase the FSH and LH, and then again mid-cycle FSH or LH surge will be there, and that again will help in the ovulations. Okay, so the cycles, like the repeated cycles. I know this is a little bit confusing, so we will make it again. I will repeat everything, so just keep listening for now. Okay. Follicle stimulating hormones. I told that follicle stimulating hormones, what it do? It stimulate the follicles. Follicle stimulating hormone, it stimulate the follicles. See, follicular stimulate the follicles. So follicular formations, like every day there is a 2 mm per day follicles will be there, and each day there will be the 2 mm per day, 2 mm per day, 2 mm per day. There is a one size will be attained. Like for examples, that is the 14 mm. If the 14 mm size is attained, so this is the size of dominant follicles. This is the size of the dominant follicles. This is the size of the dominant follicles. Then this 14 mm, what it will do? It will keep growing, and it will reach to the 20 to 20 mm, and that is what mature. That will be the mature follicles. That will be the mature follicles. Now what happen? Initially there is a many follicles growing, like millions of the follicles they grow together, and as soon as one follicle they attain the maximum size, they will attain the maximum size of 14 mm. Then what about other follicles? They will start regressing. Now onwards this 14 will grow and it will be form the mature follicle. So that's why we studied here that there is a negative feedback on the FSH, there is a decrease in the FSH. So only one follicles will grow. When the negative feedback will be there, all the follicles will be regressing out. Only the one follicles will grow only, that is the dominant follicles, and it will grow and it will become the mature follicles. It will become the mature follicles. So primary follicles, then there will secondary follicles, then tertiary follicles, and after that there will, after the tertiary follicles there will be the formation of the corpus, luteum, formation of the corpus luteum. Now this corpus luteum, it is supported by the, which hormone support the corpus luteum? It is supported by the luteinizing hormones. It is supported by the luteinizing hormones. And when the this corpus luteum will be formed, so it will be formed after the ovulations. It will be formed after the ovulations. So once the ovulation has been done, so after the ovulation the corpus luteum will be formed. Or how it will be formed? It will form by the rupture of the tertiary follicles, or we call also the Graafian follicles, the mature follicles. Or I can write it here, the rupture of Graafian or tertiary or mature follicles. So when this, there is the rupture, there is the formation of the corpus luteum, and this will supported by the luteinizing hormone. This will be supported by the luteinizing hormone. What is the color of the corpus luteum? Remember, this is the yellow color. This is the yellow color. Yellow color. And why the yellow color? It is due to carotene. Due to carotene. Carotene, we know that is the yellowish pigment. That's why it gives the yellow color to the corpus luteum. This is supported by the LH that we discussed, but this is the case that we seen in case of the non-pregnant lady. This is seen in the case of the non-pregnant lady. If we're talking about the pregnant lady, so this in initial there is supported by the luteinizing hormone, but later on in pregnant lady, in pregnant lady, corpus luteum supported by the which hormones? Which hormone? SCG, woman choriogonadotropin hormones. That is the SCG hormones. Okay. So formation of the corpus luteum supported by the LH in the non-pregnant. In pregnant lady, it is supported by the SCG. Okay. I hope this is clear and this is done. Okay. After that, menstrual cycles we studied. See, we will be having the menstrual cycles. So this menstrual cycles is of average if we take, so it is the 0 to 28 days. In menstrual cycle we was having the three phases. What three phases in the menstrual cycle we see? The first phase that we see is the follicular phase or the proliferative phase. This is the 14th day. Then this first period we called it as the 0 to 14th, that we called it the follicular phase. The follicular phase, or we can also call it as the proliferative phase, where the follicles will be proliferation phase or the proliferative phase. This phase is what? That is the luteal phase. This phase we call it the luteal phase. Why the luteal phase? Because of the thicker cells. There is a lutein cyst that we call the luteal cells. Thicker cells, due to thicker cells you can say. And luteals, in thicker cells you see that there is a progesterone formations. So after, due to which we called it as the luteals. And after that We can also call it the secretory phase. We can also call the secretory phase. Why the secretory phase? Because of the secretion of the progesterones, and this maximum progesterone secretion occur on the day 22. The maximum progesterone secretion occur on the day 22. Now this follicular phase, this is main hormones here is the FSH and LH, and who give them feedback? The estrogens. 14th day there will be the ovulations, the ovulation periods. Also remember one more very important point. This luteal phase or the secretory phase, this is a fixed. What the meaning of fixed means? It will always be 14 days, always 14th day. Always 14-day periods. So it means if we are having the 30-day cycles, so can you tell me which day ovulations will occur? If we are having the 30 days menstrual cycles, so which day ovulations will occur? If we are having the 16th, very good, very good. So see, this is fixed period. This one is the luteal phase. Sorry, this is not cell. There is a luteal cells. That's why I wrote it the luteal phase. There is a luteal phase. The luteal phase, that is a fixed period. So if you are having the 13th, so on the day 16th we see that there will be the ovulations will occur, and the follicular phase will become the follicular phase will become the how many days? 16 days. So this will become the follicular, that is the 16 days phase, and this is again the every time this will be the fixed. So that's why we are having the ovulation. So this ovulations, it depends on the the ovulation depend on the follicular phase or the proliferative phase, because this is not fixed phase, and it can having like it can due to this phase only we are having the long cycles, small cycles, but luteal phase will be always be fixed. Okay. And this process I already told you, there is a we having the hypothalamus. So hypothalamus will act on the anterior pituitary, then FSH will comes, the and this follicle stimulating hormones, and this follicle stimulating hormones will act on the which cell? This follicle stimulating hormones will act on which cell? Granulosa cells. And these granulosa cells, what they will do? They release the estrogens, and the estrogens, when the estrogens will be released, they will give the negative feedback to the FSH. Okay, my work is complete. Now you can give me the negative feedback. Then FSH will comes, LH will be rise, and when the LH will be rise, so there will be the LH peak, and at the LH peaks we will see there will be the ovulations will be occur. Okay, I hope this is clear. Then after that we will having the secretory phase. Secretory phase, I told you that in the secretory phase I told that the progesterone level will be maximum at the day 22 of the cycles. Progesterone level maximum at day 22. Why at the day 22? Because at day 22 corpus luteum will attain the maximum size. Corpus luteum will attain the maximum size. Will attain the maximum size, and it have the max and activity. Day 22 according to the we having, or day 8 after ovulations. Maximum day 2 or day 8 after ovulation. Then remember what the corpus luteum, I hope everyone know, they will release the progesterone. The corpus luteum, what they do, they release the progesterone, and this progesterone, they release the or the form the progesterone. Okay, no, I'm not reaching the release, I know that you will confuse. So what they will do, they secrete the progesterone, and when the progesterones will be secreted, so what they will help, they will try to maintain the endometriums. They will maintain the endometriums. Now see, if there is a endometrium is maintained and there is a progesterone levels, if the sperm will come, okay, if the sperm will comes and it will fertilize, then there is a secondary oocytes will forms. The secondary oocyte for the zygote will forms, and that this corpus luteum will continue to develop, and after that it will taken by the this progesterone's formations will taken, or the endometrium maintaining is taken by the HCG hormones. But in case if fertilization if fertilization occurs, corpus luteum continue to grow. Corpus luteum will continue to grow. If fertilizations does not occur, if fertilizations does not occur, then what happen? The corpus luteum will regress to corpus albicans. Will regress to the corpus albicans. Okay, this corpus luteum will regress to the corpus albicans if fertilizations will not occur, and the body will try to. Then endometriums, we know that it having the many blood, all the this endometrium will be set off and the menses will occur, and after that the cycles will continue to repeat. Okay, these things you need to remember very importantly. So main hormones, like some you can say one liner or some important points. Main hormones on the first half of the cycles. The first half of the cycles we called it the follicular phase. So the follicular phase, FSH energy, that is secreted by the, or that is maintained by the estrogens. That is maintained by the estrogens. So first half of the cycle, the main hormone is the estrogens. Then on the second half of the cycle, the main hormone is the progesterones. The main hormone is the progesterones. Okay. Follicular phase, the second things we discuss, that the follicular phase is variable phase. The follicular phase is the variable, and the luteal phase is what? That is fixed. It having the fixed durations. What will be the day of ovulations? The day of ovulations. So the total length of the cycle minus 14. Total length of the cycles minus 14 will be the ovulation. That will be the ovulations. And corpus luteum, I already told you that a hormone that maintains the corpus luteum in the non-pregnant female, that is the LH hormone. In pregnant female, that is the HCG hormones. Okay, and like if we talk about the lifespans, it will be around the this point you can write lifespan of corpus luteum in non-pregnant. In non-pregnant, it will be, and in pregnant, it will be 10 to 12. It will be 10 to 12, 10 to 12. But there will be the difference in the, here we having the date. Yes, in non-pregnant we know that it will be regress very early because of there is no fertilization, so it will be the 10 to 12 days. but in the pregnant lady you are having the, need to remember, with the 10 to 12 weeks. Sorry. Okay, that you need to understand that this is the things, and after that we will be having the, okay, just let me repeat these things. So we studied that the term pregnancy, this one you will do, I know. Menstrual cycle, there is average period 28 days. At puberty we having the hypothalamus pituitary actions. So this hypothalamus, what they will do, they will release the GnRH in the pulsatile manner, and the anterior pituitary, they will act on the anterior pituitary will release the FSH and LH. This FSH and LH, they will act on the granulosa cells. So one question here, that which cell secrete the estrogen. So which cell is that? That is the granulosa cells. Which cell is that? Granulosa cells. Then we having the negative feedbacks on the LH, positive feedback on the inhibin B, negative feedback system on FSH. Increase LH. So increase the LH surge. The LH surge occur 36 hours before the ovulation. The LH surge is 36 hours before the ovulation. This LH hormone, they will act on the thicker cell as well, and thicker cell, what they will do, produce the androgens. What they will do, they produce the androgens. And granulosa cells, they will secrete the small very small amount of the progesterone, because granulosa cell mostly they are responsible for producing the estrogen hormones, but little amount of progesterone also secreted by the granulosa cells in presence of the luteinizing hormones. Then we are having the LH peak. The LH peak, what is that? That is the 10 to 12 hours before ovulation, that we call the LH peak. What is that? Minimum amount of LH required for the ovulations. Then you are having the aromatase. So if aromatase enzymes is there maximally present in where? In the adipose tissue, what they will do? They convert the androgens into the estrogens, yani ki, or we call it the estrogenone. Why? That is the E1 hormones. Action of LH, ovulation, formation of estrone, formation of what? Progesterone. FSH, every day there is 2 mm per day formations, follicle formations. So 14 mm, that is the dominant follicular size. Mature follicle size, the 20 to 22 mm, or you can write it, it is the 18 to 22 mm, and the average will be the 20 mm. The average of it will be the 20 mm. Make it the corrections. It is the 18 to 22 mm, and the average is what? 20 mm. Then there is a formation of what? Corpus luteum. How the formation of when there is a rupture of Graafian follicle, tertiary follicle, or mature follicle, there will be the formation of the corpus luteum, and this corpus luteum is supported by the luteinizing hormones after the ovulation. See, yellow color, it is the yellow color. In pregnant lady, it is supported by the SCG. Then we having the 3 phases. One phase we have the follicular phase, the second phase we have the ovulation, and third phase we having the luteal phase and the secretory phase. The menstrual phase we having the 3 phase: follicular, ovulation, and the luteal phase. The follicular phase, what they will release, they will form the estrogen, and they will form the FSH, and the LH formations will be there, and the main hormone is the estrogen. Then we'll be having they maintain the FSH and LH amount. Then we have the luteal phase, that is the fixed phase, that you need to remember always. How many days? 14 days periods. Then progesterone level, that is maximum at the day 22. Why it is maximum? Because the corpus luteum will attain the maximum size of activity at the day 22 or the day 8 after ovulations. Tell me if we will be having slight, if I give you one question, if I give you one question, that if in case of the menstrual cycle, that is the duration of the menstrual cycle is 32 days. The duration of the menstrual cycle is 32 days. What is the day of ovulations? The day of ovulations do, and uh, which day the progesterone level will be maximum. So progesterone will be very very high on which day? 18, 32 minus 15. 18 do, okay, First question, what is the answer of the first question? That is the 18. That is the 18. What is the answer of the second question? What is the answer of the second question? When the progesterone level will be maximum? तुम्हारी मैथ कमजोर है, कोई 26 बोल रहा है, कोई 24 बोल रहा है ना? तुम्हारी गलती है ही नहीं यार। 18 प्लस 8 कितने होते हैं? 18 प्लस 8, एक 25 बोल रहा है, 26, 27, 28 सब लगा दो। मिश्रा जी 18 प्लस 4 2 18 प्लस 20 और ये कितना हुआ? 6 हुए। 24 माइनस 18 6, इट विल बी 26। दूसरा भी गलत है मिश्रा जी, 26 होगा। क्या होगा? 26। ठीक है, तो ये क्या होगा? there is a progesterone level maximum on the day 22 or the day 8 of the cycles. So अगर हमारे पास कब का आ रहा है? 18 का आ रहा है, तो 18th डे है, तो 18th डे के बाद प्रोजेस्टेरोन यार 18 प्लस 8 ही तो ऐड करना है ना, तो 18 प्लस 8 कितना हो गया? 26। 18 प्लस 2 20, 20 प्लस 6 26। ठीक है, कोई बात नहीं, मैथ मत पढ़ने बैठ जाना अभी। The progesterone levels then at day 22, day 8 after ovulations, corpus luteum will attain the maximum size or activity. What they will do? They secrete the progesterones. What they will do? They secrete the progesterones. Okay. Then if fertilization occur, the corpus luteum will continue to grow and they will continue to produce the progesterone. If fertilization does not occur, the corpus luteum will regress to the corpus albicans. The main hormone on the first half of the cycle, estrogens. Second half of the cycle, progesterone. This one we already did. Ovulation, the total length of the cycles, lifespan of the corpus luteum in non-pregnant or the pregnant 10 to 12, but in non-pregnant there is 10 to 12 days and pregnant lady is 10 to 12 weeks. After that, these functions will be taken by the HCG, human chorionic gonadotropins. Who secrete the HCG? Secreted by placenta. Who secreted by placenta. Okay, so ovulation set occur due to LH and also some amount of FS also required. Okay, तो चलो थोड़ा सा hormones के बारे में पढ़ लेते हैं. We studied that कि जो corpus luteum है वो secrete करते हैं कितने hormones? Corpus luteum हमने एक तो पढ़ा. Corpus luteum, what they do? They secrete hormones. कौन कौन सी hormone secrete करता है? The one we know that is the progesterone hormone, that is the main hormone or the predominant hormones. Other than that, they also secrete the estradiol. They also secrete the estradiol. Estradiol. Progesterone, that is the main hormones. Progesterone, that is the predominant hormones. Predominant hormones. And there is a inhibin A hormones. Inhibin B, we studied that it's under the when the FSH and LH will be there and act on the granulosa cells and that will release the estrogen. Inhibin B hormone. Here is what? Inhibin A hormone. Inhibin A hormones. And also remember there is a one more hormone that called relaxin. That called relaxins. So this relaxins will be secreted in only in pregnant lady. Only in the pregnant lady. So if any pregnant lady, you will see there is a 4 hormones that is secreted by the corpus luteum, but in non-pregnant there is only 3 hormones will be there: estrogen, progesterone, inhibin A hormones will be there. Okay. Then there are many questions on this concept also. The progesterone we know that is the predominant hormone. Okay, what is the function of these hormones? The functions of this hormone, they support the endometriums. They support what? They support the endometrium. They support the endometrium. They will keep holding that. They will keep stabilizing that. They will help to maintain the integrity of the endometrium. They will help to maintain the endometrial thickness as well. Along with that, they release the secretion of glycogen. This one I know everyone knows, but along with that, progesterone have other functions also. That is the secretion of the glycogens and lipids. Why this glycogen and lipid secretion? Because these provide the nutrition to the fertilized ovum. When the ovum is fertilized, they become the zygote, and the zygote, they need to become the zygote, and everything is done. You know that in pregnancy, progesterone, everyone is speaking progesterone. That is main hormones in the pregnancy. And after that, HCG will comes, and HCG will also help to maintain. But here we having the progesterone, the secretion of the glycogen or the lipids, which are like very stored in the vacuole formations, and this will help in the nutrition to fertilize ovum. And also remember, from your crop 2 point of view, this question will not be asked, but like for the further preparations, this is the earliest histological feature of the secretory endometriums. Secretion of glycogen and the lipids means there is secretion. So this is the earliest histological feature that we see of secretory endometrium. This is your Indian license exam questions, secretion of glycogen or lipids. After that, there is one more things that progesterones do. We all know that is called the vasodilators. It acts as the vasodilation. It acts as the vasodilations, and we can also call it the smooth muscles relaxants. Smooth muscle relaxant. Why it need to be vasodilations? Because they increase the I told you that it help in the pregnancy very much. So when the ovum is fertilized and everything is well formed, then endometrium is need to grow, and for that the endometrium need the blood supply and they increase the blood supply to endometriums. They increase the blood supply to the endometriums. Okay. Okay, so that is you need to understand. Okay, this is what we having the progesterone. Anything remaining in this? Okay, so I was telling you the name of estrogen as well. So remember the estrogen also. When we talk about the estrogens, so mainly we are having the four hormones: E1, E2, E3, and the E4. What is the E1? That is the ester 1. You can remember it like that. Ester 1. So how it will be formed? From aromatization. Which hormone? Aromatizations. Which hormones will be there? That is the aromatase enzymes. Then E2 is the estradiol. Estradiol. The estradiol is there. That is the main in reproductive age. This hormone is main in reproductive age. That is estradiol. In both reproductive age means it's both pregnancy also or in the non-pregnant also. E3 is what? Estriol. Estriol. This is mainly seen in the pregnancy time. And E4 we having the estertatrol. That is also seen in pregnancy, and they both are the synthetic hormone. They both are the synthetic hormones. The above E1 and E2, this E1 and E2, remember guys, this is the seen in both these conditions, like they are the natural estrogens. They are the natural estrogens. Okay, the esterone or the estradiol, they main in the reproductive age, and the E1 is the estrone that is formed from the aromatizations. Okay, so we having these are the four natural hormones: testosterone, estradiol, estradiol. The estrone that is formed from the aromatizations, estradiol that is the main seen in the reproductive age. E3 we having the estriol or the tetrol that is formed during the pregnancy, and they are synthesized by the syn नहीं नहीं wait, it's not synthetic, it's synthesized by placenta. They synthesized by the placenta. So these hormones E3 and E4, they are synthesized by the placenta at the time of pregnancy. Okay, that this one is the important point here. That is the maximum, which is the maximum amount of estrogens in the reproductive age. So that is the estradiols. In what, which estrogens will be more in the menopausal lady. So that is the esterols. Menopausal lady. Synthetic hormone that I was talking, that was, oh, we finished the paper here. Okay. So there was a synthetic hormone. Synthetic hormone was the ethinyl estradiol. Ethinyl estradiol. They are the synthetic hormones. They are the ethinyl they have synthetic hormone ethinyl estradiols, and these are what we have in the natural hormones. These we are having the natural hormones. Okay, we have the esterone, estradiol, estriol, estrol, they are natural. Synthetic hormone, ethinyl estradiol, no need to worry. Remember about the synthetic, just remember the main hormone is the E1 and E2. They can ask you which hormone is the main in the reproductive age, that is the estradiol. That you need to remember. Okay. Okay, just give me a second so I can open that thing. Okay, just give me 5 minutes and I will come back. let's come back. Just a second, I will come. ये रहा, ठीक है। देखो यहाँ पे क्या है, एस्ट्रम फ्रॉम एरोमेटाइजेशन, एस्ट्राडाइल मेन इन द रिप्रोडक्टिव एज, then we have the E3 estrioles pregnancy and esterols, that is the pregnancy, and these are the synthesized by the placenta, and these are the synthesized by the placenta. So the synthetic hormone, that is ethinyl estradiol. What is the function of estrogens? The function of estrogens, that I'm writing it here. So estrogens, we know that help in the, they increase the myometrial contractions. They increase the myometrial contractions. They increase the myometrial contractions. They make the cervical, or the cervix thin. They make the cervix thin, watery, profuse. While the, if you talk about the progesterone also, the progesterones make the cervix thick, watery, and the profuse. You can write it here also. The progesterones, progesterone, they make the cervix thick, and if you talk about the estrogen, they will make the cervix thin, watery, and profuse. While the progesterones, what it will do? It will make the cervix thick, scanty, thick and scanty. And these things will seen in the secretory phase. Then we have the, if we talk about the estrogens, it will make the cervix thin, watery, and profuse. Then if we talk about uh, about the endometrial glands, so they will increase the formations. They will increase endometrial gland formations. They increase the endometrial gland formations. That is the function of estrogens. While the progesterones and estrogens, they both increase the uterine size. They both increase the uterine size. Progesterone, we studied that they increase the, they have the secretory change. So when they increase the endometrial gland formations, and what they will do, they help in the secretory changes. What the secretory changes? They secrete the glycogens or the fat or lipids, and they help in the, like in the form of the vacuoles. Okay, so remember we have the estrogens, they increase the myometrial, both they together they increase the uterine size, and that will help in the pregnancy. And after that, let's discuss related to our the things, I think, about puberty. The puberty topics that can be the asked, and that is the easy topic. All other things we will keep discussing whenever we will discuss about all those topics, and all those questions. When we will discuss, we will cover that thing. Whatever will be the remainings, but these are like the very basic things that will be asked in the all the questions, so that's why we took it here. ठीक है, तो आफ्टर दैट प्यूबर्टी, देखो प्यूबर्टी क्या होता है कि एक वो स्टेज ऑफ द डेवलपमेंट, द स्टेज ऑफ डेवलपमेंट व्हेन द सेकेंडरी सेक्सुअल कैरेक्टरिस्टिक्स अपीयर्स, that we call the puberty, the stage of developmental of the secondary sexual characteristics. And this is very important topic from all exam point of view, and very important for the croak too. The stage of the development of the secondary sexual characteristics. देखो, when we talk about the secondary sexual characteristics, the secondary sexual characters in male, it is like governed by the testosterone, but in the females it is governed by the estrogens. Secondary sexual character in female it is governed by the estrogens. In males it is governed by the testosterones. Okay, that you should remember for that. What is the puberty age? That age in females. The age in females we call it as the 8 to 12 years. 8 to 12 years. If we took an average for the mean, that is the 10.5 years. The age in females that 8 to 12 years, average 10 to 10.5 years. Then remember that we will having the sequence of the changes. That is again very important topic. Sequence. What are the sequence of the changes we seen in case of the puberty? See, what are the sequence of the changes? The first change that we see, like they're the different in boys as well as in the girls. So let's make a table and do like that. If we talk about the boys or there is a girls, so in the boys first there will be the testicular enlargement. First pubertal signs, that is the testicular enlargement. Then we will be having, after the testicular enlargement there will be the second thing, that will be the penile enlargement. There will be the penile enlargement. And the third thing that we see in case of the boys, that will be the facial hairs. That will see the facial hairs. Okay, so we have in the TPF. That is the TPF. TPF. That is the TPF. You can remember तेरे PF. तेरे PF कहाँ है? तेरे PF कहाँ है? PF वगैरह ये सब कौन करता है? बॉयज करते हैं, है ना? PF वगैरह इनका सबका चक्कर बॉयज, लड़कियों को कुछ और, लड़कियों को ये सबका चक्कर नहीं रहता है. ठीक है? That is the girls. What will be seeing in the girls? So you need to remember तेरे PF. तेरे PF कहाँ है? So your TPF, the testicular enlargement, penile enlargement, and facial hairs. The girls will be having the thelarchy. The girls will be having the thelarchy, that is the breast development. There will be the breast development will be there, and this is the earliest sign. This is your questions. Which is the earliest signs that is seen in the girls, and the earliest puberty sign, that is the thelarchy. Earliest sign that we see. After thelarchy, we will be having the puberchy. But puberchy, or after the puberchy, we will be having the menarche. Menarche means first menses. That is the first menses that we see, menarche. Thelarchy is what? Breast development, then puberty, or then menarche. Then what is that time? You can remember it, the TPM. What is the TPF or TPM? Here, here we can't have the testicular. Here we can't have the testicular enlargement. Here we can't have the penile enlargement. So maintain according to that. ठीक है? तो तेरे PF or TPM, or you can also time. What's time now? PM time. This time now PM time. Okay, the time PM, time in PM. That is thelarchy, puberty, menarche, testicular enlargement, penile enlargement, and the facial hair. ठीक है? That you need to remember. अब उसके लिए जो हम अगर puberty की बात करते हैं, for puberty we will be having the Tanner charts. We will be having the Tanner chart. In the Tanner chart, the important one is here the grade 3 and grade 4. The grade 3 and grade 4. So for the boys, for boys in the grade 3, what we see, there is increase in the length of the peniles. There is increase in length of penile. Increase in the length of the penile. That is seen in the grade 3. There is soft hair begins to curl. Soft will be there. Hair will begins to curl in case of the boys, and that is done in the grade 3. In grade 4, what will be there? The increase in the girth, thickness. Increase in the girth of the penis and glans. Along with that, there will be darkening of the scrotum will be seen. The darkening of the scrotum will be seen. So girth of the penis क्या हो जाएगी? That will become thick. In case of the girls की अगर हम बात करें तो girls के केस में क्या होगा? In grade 3 there will be the generalized breast development. So they can ask you in which grade there will be the generalized breast development occur. So that occur in the grade 3. That occur in the grade 3, and again here hair begins to curl. Hair will begins to curl. Pubertal hairs, not normal hair. ठीक है. ग्रेड 4 में क्या होगा? इन ग्रेड 4 there is a nipple and areola. Nipple and areola form a second mount. Form a second mound over the breast. तो निप्पल और जो एरियोला रीजन है दैट विल बी सेपरेटली विजिबल mound over the breast. So that will be easily separated, and that can easily be seen the separated things. So that is seen in the grade 4. So we having the grade 3. तो grade 3 के अंदर ये कंडीशन आ गई. उसके बाद हमारे पास grade 4. तो grade 4 में क्या होगा? Increase in the girth of the penis and the glands, the darkening of the scrotum, nipple and areola, they forms a second mount over the breast. Okay. These are the two important grades that you need to remember. In the grade 1 there is a pre-pubertal period. Grade 2 there is a reddening of the scrotum in boys. Breast budding will be seen in the girls. You can understand from now onwards कि अगर इससे जो पहले का part है, the parts the grade before the grade 3 there will be what can be there, generalized breast development. Okay, in grade 3. So in grade 2 we will be having the breast bud will be there. The budding of the breast will be there. Hair will not be straight. Hair will straight in the grade 3. So there in the grade 2 we see the straight hairs. उसके बाद क्या होगा? After in the grade 5 there will be the mature adult type will be the grade 5. Or grade 5 you can write also. The grade 5 will be the mature adult type. Mature adult type. Okay, this one you need to remember. Okay, this is what we having the about the puberty, and this is very important. If we having the puberty testicular, this point is sequence is very important that you need to remember. That is the TPM, time per मिलेंगे, time पे मिलेंगे, time PM, तेरे PF, whatever you want to remember, but remember the sequence. ठीक है. तो ये क्या होगा? टाइम पे मिलेंगे तेरे PF. ठीक है. टाइम पे मिलेंगे तेरे PF. ओके, ये भी एक निमोनिक बन गया. एंड उसके बाद TPF, TPM, सो यू कैन रिमेंबर द टाइम, व्हाट टाइम, PM टाइम. और हियर व्हाट टाइम, PF टाइम, PF टाइम. ओके, अब देखो अभी क्या होता है कि प्यूबर्टी आ जाती है. अभी कईयों में क्या होता है कि जल्दी प्यूबर्टी आती है, कईयों में क्या होता है लेट प्यूबर्टी आती है. तो इन सम वी गॉट द लेस puberty before, and in some we got the puberty later on. So we call these conditions that is a precocious puberty. Precocious puberty, समय से पहले puberty का आ जाना, उसको क्या बोलेंगे? Precocious puberty. If secondary sexual character develop before 8 years, if secondary sexual character develop before 8 years, so we called it as the precocious puberty. Called that as the precocious puberty. What is the most common cause? Idiopathic. The most common cause is the idiopathic. We don't know, but sometimes we call it like it can be due to premature activation of the, if there is a early or the prematurely activation हो जाए किसका? HPO axis का. Which axis? Hypothalamo pituitary axis. What is the management? The management what we will give here, we will give the continuous GnRH. What will the continuous GnRH? Okay. If देखो अगर कोई भी, if there is a increased activity, if increase activity of HPO axis, activity of HPO axis is increasing, so in that case give the pulsatile GnRH. Pulsatile GnRH. but if decrease activity of the, अगर activity of HPA axis is the decrease, in that cases give the continuous GRH. ठीक है. Then other conditions it can be, there can be the delayed puberty. ये पूरा puberty वाला topic, the all puberty topics is very important for your exam. So delayed puberty. So remember, for the delayed puberty, if secondary sexual characteristics don't develop even by 13 years. देखो यहाँ पे थोड़ा सा क्या है, you need to remember, if delayed puberty when secondary sexual character doesn't develop by the 13 years. Here the most common cause the idiopathic, और mainly ये होता है कि due to constitutional delay, like the genetical reasons can be there. The most common here also the idiopathic constitutional delay. What the treatment you will give here? That is the management. That will be the, there you give the continuous, here you will give the pulsatile GnRH, pulsatile gonadotropin releasing hormones. क्यों? To increase the activity of the HPO axis. देखो एक पॉइंट से ना सब चेंज हो गया है. So it is the 2, it is the 2. अगर so अगर to increase the activity of HPO axis, अगर हमें HPO axis की activity को बढ़ाना है, just as we studied before also, that when we are doing the pulsatile, hypothalamus is releasing the GnRH in the pulsatile manner, so it will release the FSH और LH, और वो FSH LH एस्ट्रोजन पे ग्रैनुलोसा सेल्स पे एक्ट करके एस्ट्रोजन फॉर्मेशन और इनिबिन की फॉर्मेशन कर रहा था. And so if there is increased activity of HPO axis, to increase that we need to give the pulsatile, but to decrease the activity of HPO axis we need to give the continuous GnRH. So here we can see that the premature activation of the HPO axis. So what we will give to decrease the activity, we will give the continuous. To increase the activity of HPO axis, we will give the pulsatile GnRH. Because whenever we will give the pulsatile in the pulsatile manner, there will be the increase the like receptor regulations. So that's why there is an increased formation of the hormones, and that increased formation of hormone will act more on the granulosa cells, more estrogen formations, more there will be the secondary sexual characteristics. Okay, ठीक है. अगर नहीं समझ में आ रहा ना तो देखो दिस, अगर एक बार फिर से देखो, इसको पल्सेट्स हमने वहां पे क्या पढ़ा था, हाइपोथैलेमस पल्सेटाइल मैनर में क्या कर रहा है, जीएनआरएच को रिलीज कर रहा है. तो जब पल्सेटाइल मैनर में जब जीएनआरएच रिलीज हो रहा है तो किसकी फॉर्मेशन हो रही थी, एस्ट्रोजन, एफएसएच और एलएच, और एफएसएच एलएच किस पे एक्ट कर रहे थे, ग्रेनुलोसा सेल. तो ग्रेनुलोसा सेल किसको सिक्रेट कर रही थी, एस्ट्रोजन को. किसको सिक्रेट कर रही थी, एस्ट्रोजन को. और किसको कर रही थी, इनिबिन बी को. तो वो क्या था, अगर अभी एस्ट्रोजन आ गया, अगर इस पेशेंट के अंदर इसकी इसके अंदर क्या है, प्रीमेच्योर एक्टिवेशन ऑफ द एचपीओ एक्सिस है, तो ऑलरेडी देयर इज अ पल्सेटाइल जीएनआरएच वेरी मच, सो वी नीड टू गिव द कंटिन्यूअस जीएनआरएच, एंड व्हेन द कंटिन्यूअस जीएनआरएच विल बी गिवन, सो देयर विल बी द FSH LH, or there will be due to some negative feedback mechanisms the estrogen's level will be reduced. So in that cases we will give the continuous GnRH. Okay, the same thing I repeated in Hindi, so no need to worry. There is one more thing, that is we call it the precocious menarche. We call it the precocious menarche. देखो, if menses occur before the 10 years, if menses occur before 10 years, we call it the precocious menarche. And the precocious menarche, the most common cause again idiopathic, and the management, whatever the management will give, that will give the same continuous GnRH, because this is again the type of the precocious puberty, that's why we will give the continuous GnRH. Okay, I hope this is clear. ठीक है. Everybody listening? Yes. एक छोटा सा टॉपिक और कराना था, तो वी कैन डू इट टुमारो और लाइक कर ही लेते हैं, चलो ठीक है ना, लेट्स डू इट। सो देखो कुछ नहीं है, ज़्यादा बड़ा भी नहीं है, जस्ट लिसन दैट। पेन कहाँ गया यार, पेन 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 पेन, ओके हियर इज द पेन। टुमारो टुमारो, क्यों भाई क्या हुआ इतनी जल्दी टुमारो? कर लेते हैं यार, जस्ट छोटा मोटा टॉपिक है। डिनर करते रहना यार, आ जाओ कर लो फिर करते हैं, है ना। जस्ट आई थिंक 20 or 30 minutes एंड देन वी फिनिश। आई नो तुम्हें आवाज की वजह से आज थोड़ा प्रॉब्लम हो रहा होगा, बट थोड़ा कर लो यार, सिलेबस तो एटलीस्ट थोड़ा तो सब फिनिश होगा। तो ये एबनॉर्मलिटीज, क्योंकि हमें वी नीड टाइम फॉर रिवीजन आल्सो, सो दैट्स व्हाई वी नीड टू फिनिश इट। इट्स हार्ड टू फिनिश till at the time, but let it be, we will finish everything. So that's why I'm saying whatever you are preparing now, don't think that you will get the time for revision so much. Just keep because whatever you will revise for today, that will help you in the tomorrow also, है ना। रिवीजन का एक उसूल यही है कि वट एवर जो आज पढ़ा है ना, उसको अगर तुमने आज पढ़ लिया तो रिवीजन विल मेक द इजी थिंग। बट अगर उसको एक एक महीने के बाद अगर पढ़ रहे हो ना, तो दैट विल बिकम द हार्ड। if you will make the revisions after 1 month, or you will not revise whatever you are studying today, it will be like go into the vein, everything will go into vein, nothing will be in your minds. So make sure whatever you are watching today, whatever you are listening today, make sure you revise that thing perfectly on the same day। ठीक है। So on that based, let's discuss the atypical uterine bleedings. There will be the atypical uterine bleeding. So this topic is also very important for you. The atypical uterine bleeding. So any deviation from the normal menstruation is there. So we call this the atypical uterine bleedings. Any deviations, any whatever, like if you're having the normal menstrual periods and the 0, 1, 2, 3, 4 day, if you are getting the menses on these days, on the first days, or during the like after initial of the days, so that means it's okay. But if you're getting the like the bleedings during the in the middle of the menstrual cycles, or there is a two time bleeding in the two intervals, and maybe there is a delayed or infrequent cycle, so all these will come into the atypical uterine bleedings or the abnormality of the menstruations. So whatever any deviation from the menstruations, that will be the atypical uterine bleeding. That will be the atypical uterine bleeding. First, we will be having the oligomenorrhea. There is a one term we call is the oligomenorrhea. When we called it oligomenorrhea, the oligomenorrhea, remember that if any delayed or infrequent cycles, there is a delayed or infrequent cycles, we called it as the oligomenorrhea. Oligomenorrhea is the old name. The delayed or infrequent cycle is the new name for the oligomenorrhea. If menses occur after 38 days, we called it the oligomenorrhea. But the most common cause is what? That is the PCOS. That is very common in the females. That is PCOS. That is the polycystic ovarian syndrome. This is again very important topic for your exams. So PCOS, that is the polycystic ovarian syndrome. Then second one is what? That is the polymenorrhea. So polymenorrhea is what? Will be the early or frequent cycle. there will be the early or frequent cycles. The early or frequent cycle will be there. If there will be the menses, if menses occur before, 24 days, if menses occur before 24 days, so we call it as the polymenorrhea. अगर menses हो रहा है कब, बिफोर 24 दिन से पहले अगर menses हो जाते हैं, bleeding हो जाती है, और the average cycle is 24 days, less than 24 days, we call it as the polymenorrhea conditions. Then third one is what? That is a menorrhagia. Third one is the menorrhagia. In menorrhagia, these all are the old terms, these are the new terms. Menorrhagia. Menorrhagia means there can be the heavy menstrual bleeding. There can be the heavy menstrual bleeding. Or there can be the prolonged bleedings. Heavy menstrual bleeding or the prolonged bleeding can be there. देखो heavy menstrual bleeding, if there is a more than 80 ml bleedings, we call it the heavy menstrual bleedings. And the most common cause for this condition, the most common cause is the uterine fibroid. The most common cause is the uterine fibroid. What is the most common cause of this? Most common cause of the pelvic inflammatory disease. What is the most common cause for this condition is the pelvic inflammatory disease. The most common cause of the heavy menstrual bleeding, that is the uterine fibroids. For the prolonged bleedings, if duration is more than, normal durations is less than 7 weeks. If durations is 4 to, normal duration is the 4 to less than 7 weeks, 7 days. If duration is more than 7 days, or the more continued bleedings for more than 7 days, we call is the prolonged bleedings. If more than 80 ml is there, and the most common cause is the uterine fibroid, and there is a heavy menstrual bleeding will be there. Whenever I will teach you uterine fibroid, whenever I will teach you PID, I will ask you all these things, which menorrhea or which regia will be there. The fourth point we are having the metro. Okay, metro में जाना है, कहाँ पे पता नहीं. Metrorrhagia. तो metrorrhagia will be there. That is again the old name. So we can having the metrorrhagia. There is intermenstrual bleeding. The intermenstrual bleedings, bleeding between the two menses. Is there. This is between the two menses. If the two menses, there is again the bleeding. For example, if you got the bleeding on the 30th chain, and again you got the bleedings within the 12 feb, and your normal, if normal or average cycle is what, that is again 24 or 30 days. 30 days if average cycles, but still you are getting 30 gens, you should having the menses on the 13 gens, but again you got the bleedings, that is the 12 febs, so that is we called it the intermenstrual bleeding. That is the intermenstrual bleeding. And the most common cause is what, that is the ulcerated endometrial polyp. I told you the outgrowth something, so that we call it the endometrial polyp. What if we will be having the irregular cycle? जैसे for irregular cycle, अगर for example 30 Jan को आया, 30 Jans got the periods, after that 13 Jans you got the period on the 13th Feb, after that you are getting the periods on the 15th April, after that you are getting the period on the June 5 June. So this is what, this is again where normal was 30-day cycle, but here you can see that the cycle there is 30, so it will become the February, March, April. ये तो ज़्यादा ही कर दिया मैंने, ठीक है. So means there is a irregular cycles will be there. You can say Okay, no, it's like there is a, like it will be around 30, 45 day cycles, and after that we are seeing that there is 15 April, and then we have the May, then we have the 15th, again there is 50 days, so there will be around 20 days difference will be there. So if cycle to cycle variation is there, that is cycle to cycle variations more than 20 days cycle variation, so we call it the irregular cycles. For example, there is a difference between the two menses, that is the more than 20 days, so we call it the irregular cycles. Okay. After that, there will be one more term, that is the cryptomenoria. There will be the cryptomenoria. देखो क्रिप्टोमेनोरिया में क्या होता है, इन क्रिप्टोमेनोरिया देयर विल बी द हिडन मेंसेस, देयर विल बी द हिडन मेंसेस, मेंसेस देयर, menarche is there, everything is there, but no bleeding is going outside, so we call it the hidden menses. And why it is due to anatomical reasons, this is due to anatomical obstructions. If any anatomical obstructions, of course that the blood will not come out, so that's we call the hidden menses, and the terms we given is the cryptomenoria. The most common cause for this condition is the imperforate hymens. hymen जो है वो perforate ही नहीं है, ठीक है, imperforate hymen. द हाइमन जो है वो क्या है, उसमें कोई पोर ही नहीं है, और पोर नहीं है तो उसमें ब्लीडिंग होगी, हो ही नहीं पाएगी. So if the imperforate hymen is there, then there is a no pore in that hymen, so that why we will be the hidden menses. There will the transverse vaginal septum. There will the transverse vaginal septum will be there. देखो, like for example, this is vagina, and we will see there is a transverse here, the septum is there. There is a no opening here, so this having the that conditions also we are seeing that there will be the no blood will come out, and other things can be the vaginal atresia. If the vagina will completely shrink out and there is a no opening is there, so that we call it as a vaginal atresia, and the size of the vagina will be reduced out, so that's why we will not get any menses there. Okay, what the findings or the clinically you will see, what are the clinical findings you will see. See, if you are not getting any, if you have imperforate hymens, can you having the secondary amenorrhea? Yeah, if you are having imperforate hymens, hymen is imperforate, there is a no perforation in the hymens, how it can be the blood will come out in the first itself, in the menarche itself, so the patients will be always primary amenorrhea. The primary amenorrhea patients is there. Along with that there is a cyclical pain, होगा with or without bleedings, there is cyclical pain with or without bleeding will be there, or primary amenorrhea means we can having on the menarche, at the time of the menarche, cyclical pain with the bleedings. When we do the per speculum examinations, there will be the per speculum examinations. So on per speculum examinations, what we will do? We will do the tens bluis. They do the tens bluis things. And when we do the per abdominal examinations, there will be the suprapubic bulge will be there. And like it's a common also, like whenever the any girl having the menses at the time of the menses, you will see there is something suprapubic pulse at that times, so that is we can also see in, of course there is in hidden menses is there, the bleeding is can be hidden, menses is not coming out, so at that time the menses were collected there and they will give the bulge that we call it the suprapubic bulge. And the tens bluis like hymen will be there, that will be things or the vagina will be looks the tense bluish, because this is what, this is like the mixed blood is there, so that's why it gives the bluish appearance, and that's why we will see when we do the per speculum examination, we do the tense bluish conditions. Okay, clinically there will be the primary amenorrhea, cyclical pain with or without bleeding can be there. If the imperforate hymen, transverse vaginal septum, vaginal atresia, that is the most common cause you need to remember. Okay. There is a there is one condition called the uh, hematocolpos. Hematocolpos. What is hematocolpos? See, again, if there is a blood in cervix plus vagina, hematocolpos is what? Cervix plus vagina. Colpos is what? Cervix plus vagina. Cervix plus vagina. We call it the colpox. See, blood in cervix and vagina. So we call it the hematocolpox. Blood in cervix and vagina. We call it the hematocolpox. There is another term we call it hematometra. Hematometra. So hematometra will be there if the blood in uterus is there. We call the hematometra. The blood in uterus we call it the hematometra. Then we having the hematosalpinx. We having the hematosalpinx is there. That is the blood in fallopian tube. Blood in fallopian tube there. हेमाटोसाल्पिंक्स. साल्पिंक्स देखो, मेट्रा क्या होता है? यूट्रस होता है. साल्पिंक्स क्या होता है? दैट इज द फेलोपियन ट्यूब. दैट यू रिमेंबर आल्सो. द साल्पिंक्स इज क्या होता है? साल्पिंक्स किसको बोलते हैं? फेलोपियन ट्यूब. वी डू आल्सो डू द साल्पिंजेक्टोमी, साल्पिंजोटोमी. वी विल डिस्कस दोस थिंग्स व्हेन द ट्यूमर विल कम. सो साल्पिंक्स, रिमेंबर, दैट इज द फेलोपियन ट्यूब. There is other conditions can be there, that is the hemoperitoneum. Hemoperitoneum. So blood can be collected in any of these conditions, in any of these structures like colpos. Blood can be accumulated in the cervix vagina. Blood can be accumulated in the uterus. Blood can be accumulated in the fallopian tubes. Blood can be accumulated in the peritoneal cavity. Blood in peritoneal cavity. Okay. And also remember, what the complication of endometriosis, the complication of endometriosis, the complication of the cryptomenorrhea. What is that? That is endometriosis. What we will do in case of the imperforate hymens? Just telling you. No, it will not be asked. ठीक है, अगर देखो imperforate hymen अगर हुआ तो हाइमन इम्परफोरेट है. ठीक है. सो व्हाट वी विल डू, वी विल मेक ए क्रूशिएट लीजन्स. इस तरीके के लीजन्स क्या बनेंगे? इंसिजन बनेंगे. क्या बनेंगे? क्रूशिएट इंसिजन, एक्स शेप्ड इंसिजन. इसको बोलते हैं क्रूशिएट इंसिजन. इसको बोलते हैं क्रिस क्रॉस इंसिजन. इसको बोलते हैं डायगोनल इंसिजन. तो इस तरीके का इंजेक्शन लगाएंगे और उसको हम परफोरेट कर देंगे. ठीक है. और अगर इफ देयर इज ए सेप्टम इज देयर, तो सेप्टम को हम निकाल फेंकेंगे ताकि ब्लीडिंग आ जाएगी अपने आप बाहर. ठीक है. तो कोलपोस यू नीड टू रिमेंबर, सर्विक्स प्लस वेजाइना, मेट्रा uterus, salpinx, fallopian tubes, peritoneal cavity. Okay, this is what we discuss. एक और टर्म होती है जिसको हम बोलते हैं हाइपोमेनोरिया, क्योंकि हमने क्या पढ़ा है? Hypomenorrhea, because we studied about which conditions? We studied the hypo, like there is a more amount of the bloods. We studied that is the menorrhagia. Similar type of the conditions we see, that is the hypomenorrhea. In case of the hypomenorrhea, what we will be having? There will be the light menstrual bleeding. There will be the light menstrual bleedings. Light menstrual bleedings, देखो नॉर्मल ब्लीडिंग जो होती है ना, वो होती है 20 से 80 ml के बीच में. 20 से ml, अगर लेस देन 20 ml से कम ब्लीडिंग है तो भी प्रॉब्लम है, अगर 80 ml से ज्यादा ब्लीडिंग है तो भी प्रॉब्लम है. लाइट मेंस्ट्रुअल ब्लीडिंग है, और इसके अंदर क्या हो सकता है? ब्लीडिंग शॉर्ट, यानी कि सिर्फ 2 दिन के अंदर ब्लीडिंग रुक जाए तो शॉर्ट एंड ब्लीडिंग दैट विल बी अराउंड लेस देन 2 days. दैट विल बी अराउंड लेस देन 2 days. तो इसमें देखो, इसका जो मोस्ट कॉमन कोज होता है ना, मोस्ट कॉमन कोज, तो मोस्ट कॉमन कोज क्या होता है, दैट इज द एशरमैन सिंड्रोम्स. द मोस्ट कॉमन कोज इज द एशरमैन syndromes. The most common cause is the Esserman syndromes. Esserman syndrome में हम पढ़ेंगे आगे जाके. In Esserman syndrome we will study there is a formation of what? The formation of what? Synecdoche or adhesion formations. ठीक है, I will show you the image also at that time. और like band type की formation हो जाती है at the or the band type formations will be there. We call the synecdoche or the adhesion. So fibrous band formations that जिसकी वजह से क्या होगा, that prevent the endometrial perforations, that prevent endometrial proliferation. तो उसकी वजह से क्या होगा कि जो endometrial proliferation है वो रुक जाएगा, और endometrial proliferation अगर होगा, रुक जाएगा, so there will be the thin endometrium will be forms. So what it will there, prevent the endometrial proliferations, and due to which thin endometrium is there, and due to thin endometrium there will be the less bleeding will be there, because the less amount of endometrium will be shed off, so that will become the thin endometrium will be there. And also the remember the most common cause, the most common cause of Esserman syndrome, that you need to remember कि इसको हम बोलते हैं, जैसे फॉर एग्जांपल जब हम when we do the postpartum, देखो एक होता है ना क्यूरिटा, एक सफाई करनी होती है, जब whenever the bleedings will occur, so whenever the delivery will occur, तो एक टाइम आता है जिसको बोलते हैं पोस्टपार्टम पीरियड. उस पोस्टपार्टम पीरियड के अंदर क्या होता है, एक झाड़ू लेते हैं, झाड़ू से पूरे यूट्रस के अंदर की क्या कर देते हैं, सफाई कर देते हैं. उसको क्या, उस टेक्निक को क्या बोलते हैं, क्यूरिटाज. ठीक है, तो उसको क्या बोलेंगे हम, क्यूरिटाज. तो उसको बोलते हैं पोस्टपार्टम. इसको बोले जैसे कहीं भी जाओगे ना हॉस्पिटल में, तब भी ये बोलेंगे सफाई करना. तो सफाई मतलब लाइक पूरी यूट्रस की क्या हो रही है, पूरी सफाई कर देते हैं. तो जितने भी वो फाइबर्स और बैंड्स हैं वो सारे क्या हो जाएंगे, तो उसकी वजह से क्या होता है, फाइबर्स बैंड्स वगैरह की फॉर्मेशन हो जाती है. ओके, so remember that in the Esserman syndromes what we do, like when we having the delivery, so after the delivery we will be having the period, we call it the postpartum periods. Partum means delivery periods, and after the delivery we call it the postpartum periods. So whenever the postpartum period will occurs, we will be having the curettage, and with the help of that curettage what we will do, we will clean all the uterus, and due to that there will be some fibrous band formations between the endometriums, and that will cause the Esserman syndromes. Then there is a other things, that the post-abortal curettage. Then there is a other cause that can be the endometrial. Post-abortal means after the abortion. Endometrial tuberculosis. Then we'll be having also remember the schistosomiasis. There is a, we call also the schistosomia, river fluke, schistosomiasis, but this is what rare cause. The postpartum curettage, post-abortal curettage अगर करना है तो that will cause main cause of the Esserman syndromes. Okay. Okay, the last one we having, after that we will remain with the amenorrhea, or okay, this one we will discuss in the next class, dysmenorrhea or the amenorrhea, क्योंकि वो that will become the big topic.